Good morning. It is my pleasure to introduce our Grand Round speaker today, the Royer Award winner, Dan Mathalon. Dan is a role model for us all. He is a rare pentuple threat. He has excelled in research. He has over 300 peer-reviewed publications and numerous peer-reviewed NIH and VA grants. He has over 40 postdocs who he mentored. So he excelled in teaching, mentoring, over 40 postdocs, many of whom have gone on to faculty positions. He's led an important clinic, our early psychosis clinic here for many years as an outstanding clinician. He has excelled in leadership and served as deputy vice chair for research for our department and is very generous with his time doing community service, serving on many of our department committees. I'm just going to say a little bit more about two of those. One is his leadership. So I've had the pleasure of getting to work with Dan in his role as deputy vice chair for research, and he's done a superb job in this role. And I really believe that the VA faculty, some of whom are here, could not have asked for a more effective advocate on their behalf. And then clinically, it is a striking indication of the esteem with which he's held that his colleagues in his clinic found out who was doing the introduction today and emailed me a blurb to read, and this says it all. Dan Mathalon is an amazing colleague. Despite being an international leader in the complex neuropsychological risk profiles of psychosis risk, he always distills this knowledge built over decades into concrete patient-centered problems and goals to be used for shared decision-making in the context of a longitudinal alliance. We have personally witnessed many family members let out a long-withheld sigh of relief after meeting with Dan. Finally, my child is in good hands. Plus, he's super fun at parties. Please join me in welcoming our Grand Round speaker, Dan Mathalon.
Okay. So thank you. I'm going to start my talk by just reminding myself and everyone where I started, which was really with schizophrenia. And as we know, schizophrenia is one of our serious mental illnesses that involves positive symptoms, including hallucinations, delusions, and disorganized thought process and behavior, and negative symptoms, including blunted affect or emotion, anhedonia, social withdrawal and apathy, and decreased motivation. And the age of onset is usually in the late teens or the early 20s. Now, the fact that it's been known for some time that in young people experiencing their first episode of psychosis, the longer they had gone without treatment prior to being diagnosed and treated, the worse the response to treatment. And this has led the field in schizophrenia to really focus efforts on trying to increase our identification and treatment availability and multimodal treatment availability in the first episode of psychosis. But it has also motivated the work to look earlier than the first episode of psychosis, with the prospect that there may be opportunities for intervention and even prevention that could come about if we could identify people early enough who are at risk for developing psychosis. And this is where the work began originally in Australia with Pat McGorry's group on defining the clinical high-risk syndrome for psychosis. So again, we've known that typically first episode of psychosis is preceded by 1 to 2 years of milder forms of symptoms that emerge along with decline in functioning in school and in work. And McGorry's initial definitions have stuck and been validated. There are 3 ways to be considered at clinical high risk for psychosis. Far and away, the most common way is to have what's called the attenuated psychosis symptom state. And this involves psychotic-like symptoms that are not at the full severity of psychosis, which I'll say more about in a minute. Another way is to have what are known as brief intermittent psychotic states. These are more like full-blown psychotic symptoms, but they have really short durations, so they don't meet the duration criteria for a psychotic disorder. And the third way is to meet the criteria by genetic risk and showing functional deterioration. So either having a family member with schizophrenia or being in the genetic spectrum of schizophrenia oneself by virtue of having a schizotypal personality disorder diagnosis, but also showing deterioration in function over the prior 12 months. These can be considered at clinical high risk for psychosis. In doing this work, do we draw the line? Where does full psychosis start then, and these high risk level or prodromal level symptoms end? And the definition largely centered on the idea of conviction or delusional conviction. So the point at which the individual believes that the hallucinations or the delusions are true, that is, that they're no longer ambivalent or uncertain about the symptom, not entertaining the idea that it might just be their mind playing tricks on them, maybe possibly true, but maybe not. At the point at which full conviction sets in is the point at which the field would define full psychosis. But there's also a duration criterion that symptoms have to be present for at least an hour a day, 4 days a week on average over a period of a month. And then there's a provision that if the symptoms are severe enough to be dangerous or disorganizing to the individual, so threatening to their livelihood, to their family relationships, or to their dignity, then psychosis is considered to be present regardless of the duration. And this is how the field has moved forward in looking at the clinical high-risk symptoms and syndrome as a predictor of conversion to psychosis. And this is a meta-analysis from Fuser-Pulley's group. He's done several. This is one of the more recent ones. And what it basically shows is that by 2 years of follow-up of clinical high-risk individuals, about 19% will have converted to a psychotic disorder. And by 4 years, it's at about 26%. And you can see that the conversion rate starts to asymptote over time, so that even by 10 years, it's only gone up to about 35% transition rate, which means actually that most of the people who we're identifying as clinical high risk are not likely to transition to full psychosis. That's really important to keep in mind. So the risk-benefit analysis currently, this is a consensus on the part of people who've been doing this research in the field, does not support treatment with antipsychotic medications in the CHR syndrome. So there have been some controlled trials with antipsychotics that treated for periods of 6 to 12 months and showed that some of these high-risk symptoms did improve while on the medication. However, when the medication was stopped and then subjects were followed for another 6 months, the conversion rates went right up to where the placebo group was. So the question addressed by this study, could you intervene early with an antipsychotic treatment for a period of time and essentially put out the fire that is starting to develop? The answer seems to be no, that there is no particular advantage to starting the antipsychotic early. And in fact, basically antipsychotic medications do not seem to prevent psychosis. 80% of individuals who meet the clinical high risk criteria won't develop a psychotic disorder within 2 years. So treating all CHR individuals with antipsychotics would expose many of them to side effects, including weight gain, sedation, secondary negative symptoms, and the risk of developing tardive dyskinesia, even though most of these individuals will not progress to full-blown psychosis. So this risk-benefit analysis doesn't support the introduction of antipsychotic medications at the clinical high-risk stage. And it also can obscure our diagnostic assessments and make it very hard to come up with a narrative for patients and family in terms of what it is that we're treating. So the field recognizes that there is a desperate need now for new medications that can treat symptoms and possibly even prevent the progression to full psychosis with fewer side effects than dopamine antagonists. So one of the goals of current work in this field is to develop personalized treatment approaches for CHR patients based on their profiles of symptoms, but also on consideration of biomarkers that could help to improve the accuracy of our predictions of who's at greatest risk for psychosis. So what happens to those who don't convert to psychosis? Follow-up studies indicate that about 40 to 50% of non-converters will remit from the CHR syndrome by 36 months of follow-up. And about 30% of the non-converters will have persistent or worsening CHR symptoms without transitioning to psychosis. This heterogeneity of clinical outcomes in CHR individuals is a major challenge for clinical trials with new drugs aiming to induce CHR remission and ultimately prevent psychosis from developing. This motivates research on biomarkers to improve prediction of outcomes, such as predicting conversion to psychosis, but also being able to use biomarkers to predict remission from the CHR syndrome. This would have benefit for clinical trials in terms of screening in people at highest risk, screening out people who are most likely to have a placebo response or get better on their own, and also help inform more personalized and staged approaches to treatment. So I'm going to talk about some of the biomarker work that I've been doing as part of multi-site consortia funded by the NIH. I'm going to be showing you data from the North American Psychosis Risk, or PRODROME, as we used to call it, longitudinal study, or NAPLES study. And these are the sites in North America that participated in this study. These are the sample sizes that we had. It was a fairly large sample. We're now going much higher in our current work, but 552 clinical high risk, 236 healthy controls. And I'm going to talk about EEG-based biomarkers a little bit. And before I do that, I'd like to just digress and talk a little bit about event-related potentials in EEG. So, because mostly what I'm talking about are event-related potentials. So if you look at the EEG trace in the, let's see if you get this to work here, in the top figure here, that's about 10 seconds of EEG. And shown along the x-axis on the bottom are the markers that indicate the precise delivery of a sound, of a tone. And you would be hard-pressed to look at that EEG and detect the responses to the tone each of those 10 times. But if you cut up the EEG into 1 second snippets and line it up precisely on the onset of those tones and then average them, what you end up with is something known as an ERP, or event-related potential. This waveform shows very prominently at 100 milliseconds a negativity that's known as the N100, which is an obligatory response to sound that is embedded in the EEG, but comes out through signal averaging. Because a lot of the activity in the EEG is random, it averages out to 0, and you're left with smaller excursions that are very reliable and have been studied in terms of their sensory, perceptual, and cognitive significance. So I'm going to talk, the first one I'm going to talk about is an ERP component known as the mismatch negativity, which is a response to, an automatic response to deviant sounds presented in the series of standard sounds. And it's typically a series that sounds something like this: beep, 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 beep. And one has no task. One is told to ignore the sounds, but the auditory cortex encodes this information and has a response to the deviant sound that is known as the mismatch negativity. And it is, it can be elicited by deviance in sound in any number of dimensions. So frequency or pitch, duration, intensity, or the patterns can elicit mismatch negativities. And because this is a pre-attentive signal, the paradigms are usually delivered with subjects doing something else and told to ignore the sounds. In our case, they were doing a visual task while ignoring the sounds. Deficits in mismatch negativity amplitude are well replicated in schizophrenia. There have been a number of meta-analytic reviews now, so it's a well-recognized schizophrenia biomarker. And it has been shown in non-human primate studies and rodent studies, as well as human pharmacological challenge studies, to be dependent on glutamate transmission at NMDA receptors. It's typically calculated as a difference wave. So here I'm showing the standard and then the deviant. And you can see that negative wave for the green wave showing up in the deviant. And then the difference wave is where the mismatch negativity is measured, that negative peak at around 200 milliseconds. Okay, so the Naples sample, going to talk about two types of analyses we did. One involved the entire sample of clinical high-risk individuals, where 66 converted to psychosis and 417 did not convert. This is a Cox regression analysis, or time to event analysis, where we're looking at the time from the EEG assessment to the time to conversion. In these kinds of analyses, all subjects play. And when they drop out of the study, they're censored at the point at which they drop out. As opposed to what we would call case control analyses, where we're looking at converters versus non-converters. In this case, we want to be very sure about the status of non-converters, as sure as we can be. So we limit the non-converter group to those who have been followed for a full 24 months, which is why the sample size differs in this analysis. And then we further break down the non-converters into those who remain symptomatic, those who remitted from the CHR syndrome, didn't have the symptoms anymore. And then we also have a healthy comparison group in here. And this slide just shows the overall on the top, CHR versus healthy control, small mismatch negativity reduction effect, which you can sort of make out in the topographic maps where things look a little bit less intensely blue in the CHR group. And it's a little hard to see, but the waveforms show a small reduction. But if you then break it down by the clinical outcomes, what we see is a significant group effect where the converters to psychosis had a smaller mismatch negativity at baseline relative to the non-converters, and also smaller relative to the healthy controls. And that's depicted down here. And I think you can appreciate the with the heat map, the diminished mismatch negativity in the future converters relative to the other two groups. So it's, excuse me, a second. So there was also an interesting interaction with medication status, such that in the Naples 2 study, some individuals were on antipsychotics when they came into the study. How could that be? Well, because of prescribing practices in the US, we see an increasing number of individuals started on antipsychotics at the prodromal stage. And we at that time were doing interviews to try to determine whether they had been fully psychotic when medication had been started. And if they had not been fully psychotic, we accepted them into the study. But it did have potential impact on our biomarkers. And in this case, what we saw was that the mismatch negativity effect, if I can get the cursor to work here, was significantly larger in the unmedicated subsample. So it appears that antipsychotic medication obscures to some degree the mismatch negativity sensitivity to future psychosis risk. Mismatch negativity deficits also predicted the imminence of risk for transition to psychosis. This is a Cox regression result, and it just divides up the mismatch negativity amplitudes into the 25th percentile, 50th percentile, and 75th percentile. And you can see that the rates of transition are significantly different. This is actually a continuous variable in the Cox regression, but this kind of cartoon shows the effect. So I'm going to switch now to talk about a second ERP component that I've done a lot of work with over my career, the P300. P300 comes in two flavors. The target P300 or P3B is elicited by an infrequent task-relevant target stimulus and an oddball task. Similar to what I played for you before in terms of the mismatch negativity, there are standard tones and then deviant tones. The deviant tones in this case are targets, and you have to press a button as opposed to ignoring them. And as you'll see, there's a second kind of infrequent stimulus that we use to elicit a second flavor of P300. But this one, the target P300, is thought to reflect the top-down allocation of attentional resources. It has a parietal scalp maximum, so right over here, over the back of the head. The second flavor of P300 that can be elicited is known as the novelty P300 or the P3A. It is elicited automatically by infrequent novel or salient distractor stimuli in oddball tasks. So in an auditory task, we do this by occasionally 10% of the time having a machine sound, an animal sound, a dog bark, a rooster crow, a toilet flush, things that you don't expect, but don't require a response, but they grab attention in a bottom-up fashion. So it's thought to reflect more bottom-up orienting of attentional resources relative to the target P3B. And it has a more frontocentral scalp maximum, reflecting some different generators of the P3A. Now, P300 can be elicited in any sensory modality, but most often it's elicited in an auditory oddball or a visual oddball task. There we go. And this is just a cartoon showing the P300 paradigm where we have 80% standard tones, and then the target tones are higher pitch and they're 10% of the time, and the novel sounds are presented 10% of the time requiring no response. And subjects press to the button just to the target tones. So this is showing data from the Naples study where we have the clinical high risk and healthy controls. And we do see some significant differences as a group for the target P3B and the novelty P3A. This is the auditory paradigm, as is shown on the slide here. When we break down the clinical high risk sample, though, based on their clinical outcomes, that's why we're really interested in how the biomarker performs. This is what we find. So we have 73 converters and 225 non-converters followed for at least 24 months. Here we go. And what we see is a significant reduction or a smaller target P300 in the future CHR converters that's shown in the top row relative to the non-converters followed for 24 months. We do not see the novelty P300 showing this effect. So novelty P300 was not significantly different between converters and non-converters. I'd say the button's a little quirky. Oh. Sorry about that. Wow, went back. Oh, I see I'm going back, not forward. Okay, I think this is where I left off. So I talked about the converter, non-converter effect. Now, if we break down the CHR non-converters further into those who were symptomatic, remaining with prodromal level severity symptoms, but didn't progress to full psychosis, versus those who remitted from the syndrome, no longer had prodromal level symptoms. This is the P300 results that we got. And what you can see pretty clearly is that the converters, who are shown in red, and the symptomatic patients who did not progress to psychosis but remained with prodromal level symptoms, are pretty similar in terms of the P300 reduction they show. What was very interesting is that the future CHR remitters were right on top of the healthy controls. So they had a very normal, intact P300. Any advice? Is it a battery issue? I can use this one. Okay, thank you. It's better. So this just depicts the results that I just described. I don't know where that came from. There, where what we see is that the converters and symptomatics are not different from each other, but both of them differ from the healthy controls and also from the remitters. Okay. And that's that result. Oh, so this is the result showing the novel TP3. And what this shows is that all three groups show deficits in novel TP3 relative to the healthy controls, but there were not differences dependent on the clinical outcome of the CHR individual. So novel TP3 seemed to be more of a marker of risk in general for the CHR syndrome and didn't differentiate between clinical outcomes. The target P3B also predicted the imminence of risk for transition to psychosis. So individuals who had smaller target P3Bs tended to convert to psychosis earlier based on this Cox regression. So I'm going to switch gears now and talk about a different domain, a biomarker. This comes from fMRI. And in particular, I'm going to be focusing on and talking about the thalamus and thalamic connectivity. So recent views about the thalamus converge in suggesting that it's not just a relay station, but an important player in cognition, emotion, and coordination of sensory information. Thalamus size, cellular features, thalamic activity, gray matter volume, and metabolism are all affected by schizophrenia. There is a significant literature on this in the schizophrenia field. And schizophrenia has been posited to be a disorder of connectivity. And this has generated interest because of the central role of the thalamus in connecting across cortical regions, whether thalamic connectivity in particular is affected in schizophrenia. And the answer is that there have been a number of studies now that have used resting state fMRI with the thalamus as a seed region and looked at the connectivity patterns in schizophrenia patients versus healthy controls. And what's been found has been remarkably consistent across studies, which is that in schizophrenia, there tends to be hypoconnectivity between the thalamus and the prefrontal cortex and cerebellum. And there tends to be hyperconnectivity between the thalamus and sensory motor areas and other sensory areas like auditory and visual cortices. Alan Anticevich at Yale did one of the first studies documenting this effect in schizophrenia. And again, it demonstrates what I just repeated, which is that there are areas of hyperconnectivity, particularly with sensory and sensory motor areas, and areas of hypoconnectivity, particularly with prefrontal cortical areas and cerebellum. This is a paper from our lab that compared 178 healthy controls to 183 schizophrenia patients. This is from the fBurn sample. And these are, you can see the red is the thalamus, which is where the seed is. And so there's high connectivity with itself. And if you look carefully, you'll get a sense that there is just some overall greater connectivity in schizophrenia patients relative to healthy controls. And this map shows the group differences that are significant. And in red are the areas where the schizophrenia patients tend to be more connected than healthy controls, more strongly connected, hyperconnected. And in blue are the areas where the schizophrenia patients showed hypoconnectivity relative to healthy controls. And this includes, for the hypoconnectivity, the posterior cerebellum and pons, and the thalamus itself was hypoconnected. And in terms of hyperconnectivity, and the anterior cingulate also at a lower threshold show this hypoconnectivity. And in terms of hyperconnectivity, we see hyperconnectivity with auditory cortical regions, particularly the superior temporal gyrus, and as well as sensory motor areas, pre and post central gyrus, and the superior occipital areas. We also see clinical correlations emerge with this thalamic disconnectivity. So on the left, you see correlations with the, this is with the right posterior cerebellum hypoconnectivity. So this is where connectivity is deficient in schizophrenia. And what you see is that less connectivity is associated with more severe positive symptoms, SAPS delusions, and bizarre behavior. On the right, you see the temporal gyrus. This is an area of hyperconnectivity, auditory cortical area. And this tends to go with more severe positive symptoms, more severe delusions, and more severe hallucinations. So in the Naples 2 study, we worked with Alan Anticevich and did this resting state thalamic connectivity analysis, and basically found similar things to what we were seeing in what had been reported in the schizophrenia literature. In particular, using ROIs that were defined, regions of interest that were defined from the schizophrenia study, Anticevich and colleagues found that the converters relative to non-converters and the healthy controls showed reduced thalamic connectivity with the cerebellum, the prefrontal cortex, and the anterior cingulate, and increased connectivity with sensory and motor regions. And this is something we found also in our own sample. This is from Susanna Fryer, who took the lead on this paper, showing areas where both clinical high-risk individuals and patients within the early phases, first 5 years of schizophrenia, tended to have either hyperconnectivity, as shown on the left, and these are in auditory cortical regions and temporal gyrus, and hypoconnectivity on the right with the cerebellum and with the thalamus itself. Trying to get it to move. Oh, there we go. Okay. I don't know what I clicked it twice. So I'm going to switch gears now and talk a little bit about pharmacological challenge studies and how we can use them to make sense of some of these biomarkers and kind of leverage our way into ideas about novel therapeutics in the clinical high-risk syndrome. So why do pharmacological challenge studies? What are they? So in pharmacological challenge studies, we use pharmacological probes with specific neurotransmitter and neuroreceptor effects so that we can learn which transmitter and receptor systems may contribute to psychiatric symptoms and cognitive deficits. This has been a strategy that's been in place in the field for a long time. But using just behavioral or observational readouts of symptoms or self-report has some potential biases, because in pharmacological challenge studies, it can be very difficult to blind a person as to whether they're getting the active or the placebo condition. And it can interact a lot with expectations that subjects may have about what they're supposed to experience under the active treatment. So this is a rationale for looking at pharmacological challenges with neurophysiological biomarkers. Biomarkers minimize the blinding problem and the potential demand characteristics associated with self-report. And many EEG biomarkers, in fact, can be studied in animal models. So similar effects with drug challenges on a biomarker in an animal model and in a human can help to build bridges and establish homologies between the animal models and human data. These kinds of biomarker studies can also help to validate animal models and promote novel drug development by targeting the effects on the biomarkers. So I'm going to talk about work that we've done over the years. A lot of this was data collected when I was at Yale on ketamine as an NMDA receptor antagonist and pharmacological model of NMDA receptor hypofunction in schizophrenia. So ketamine and PCP are dissociative anesthetics. They are non-competitive antagonists at the NMDA subtype of the glutamate receptor. And at sub-anesthetic doses, ketamine produces symptoms that resemble those that we see in schizophrenia, including positive psychotic-like symptoms, so perceptual distortions, sometimes hallucinations, disorganization, odd ideas, paranoia, and negative symptoms, including social withdrawal, blunted affect, and cognitive impairments, including attention and memory problems and executive dysfunction. There are a lot of studies looking at the cognitive and clinical effects of ketamine. And the PCP ketamine story is really the cornerstone of the hypothesis that NMDA receptor hypofunction may be an underlying cause or core pathophysiological mechanism in schizophrenia. And it is one of our major pathophysiological models. So animal studies, this is a lot of the work that comes out of Beta Mogadam's lab, as well as human studies that a lot of this was done by John Crystal and his team at Yale, suggest that ketamine produces its psychotomimetic effects, so the effects that resemble psychosis, by inducing excessive glutamate release. So how does that happen, given that it's a blocker of a glutamate receptor? It's thought that this happens through preferential blockade of NMDA glutamate receptors located on GABAergic interneurons. And this leads to reduced GABA neurotransmission, releasing pyramidal neurons from GABAergic inhibition. And the result is an excessive excitatory glutamate neurotransmission from pyramidal neurons. And it's known that drugs that reduce glutamate release or that increase GABA neurotransmission have been shown to block the psychotomimetic and neurocognitive effects of ketamine. And this is a cartoon that just kind of illustrates the idea that normally when things are in balance, this microcircuit that involves a pyramidal excitatory neuron and an GABAergic interneuron that has an inhibitory effect, that there are NMDA receptors on the GABAergic interneurons that get feedback from the excitatory neurons. And normally, if they're getting enough excitation here, it will release glutamate or GABA rather to keep this excitation inhibition balance in check to keep it in balance. With ketamine, by blocking the NMDA receptors with a preponderance of that blocking happening on inhibitory neurons, you end up seeing too little stimulation of the inhibitory neurons, which then do not release GABA. And that results in excessive excitation and release of glutamate by the excitatory pyramidal neuron. Sorry about that. So this is the basic idea around how ketamine is producing a lot of its psychotic-like effects. So I'm going to just talk about ketamine as a pharmacological model for glutamatergic NMDA receptor hypofunction in schizophrenia, particularly by looking at its effects on the ERP and fMRI biomarkers that I've discussed here that have established sensitivity to schizophrenia and the CHR syndrome. So first, a study that we did looking at the mismatch negativity. And if you look at the box in green, this is the saline day where that we're using to compare the other conditions. And the two ketamine days, one had ketamine alone, one had pretreatment with nicotine, which ended up not changing the ketamine effect. And what we saw, and you can appreciate this with the red and the magenta lines relative to the black, if you look on the bar graph on the right, is that ketamine reduces the mismatch negativity. And this was true for all except for the duration deviant mismatch negativity. And this has been shown many times now. There are multiple reviews and meta-analyses that document the ketamine effect on mismatch negativity. One of the strategies we used to try to ask how much the ketamine effect resembles the schizophrenia effect, we had patients with schizophrenia who had undergone the same paradigm and healthy controls. So we transformed the schizophrenia data into Z-scores relative to the healthy control data, and we transformed the ketamine data relative to the placebo day data into Z-scores. And then we took these two groups of subjects with Z-scores and we compared them. And what we see is shown here, that schizophrenia produced actually a larger decrement in mismatch than ketamine across the different deviant types. And there was a significantly smaller mismatch negativity to the duration deviant compared to the other frequency deviants. And nonetheless, the group by deviant type interaction was not significant. And overall, the pattern was similar, but just muted in ketamine relative to what we've seen in schizophrenia. Okay, and that may be dose dependent. That was just a caveat. So in terms of effects of ketamine on P300, we have a study that we're still writing up that shows that ketamine reduces the auditory P3A to novel sounds and the target P3B to target tones. And relative to schizophrenia, where again we use the Z-score approach, there was no significant difference. That is, both schizophrenia and ketamine produced very comparable reductions in the auditory novel P3A and the target P3B. And this is consistent with NMDA-receptor hypofunction models of schizophrenia, possibly contributing to the P300 reductions that we see in schizophrenia and the clinical high-risk syndrome. So I'm next just going to talk about our work looking at ketamine with thalamic disconnectivity. And this is work that I did with Sam Abram, who's here in the audience. Start with some of our earlier, so the question really was, are thalamic disconnectivity patterns that we see in schizophrenia and in the clinical high-risk syndrome mediated by NMDA-receptor hypofunction? And we tested this with the ketamine challenge. And further, to test whether the ketamine effect was mediated by this downstream increase in glutamate release that I told you is the positive mechanism, we also had a condition where we added lamotrigine, which blocks glutamate release, to see if we could confirm that this was an excessive glutamate release phenomenon. This is the basic design of the study. There were 3 test days. You could have placebo, lamotrigine, and placebo ketamine over the entire test day. So everything was placebo. You could have placebo lamotrigine, but the infusion was active with ketamine. And then you could have the active test day where lamotrigine was active and ketamine was active. And these were randomized in order across, we had 18 male volunteers for this study. This is our ketamine infusion algorithm. This is very commonly used at Yale. An initial bolus followed by a steady state infusion. And the lamotrigine dose used was 300 milligrams or a placebo. And this basically shows the results with ketamine versus placebo on thalamic connectivity from the fMRI data. And what you can see is that there seems to be an increase in thalamocortical connectivity associated with ketamine, reflected in the bottom row relative to the top row. And the purple you can see is the thalamus seed itself. Ketamine also produced significant effects relative to placebo that included excessive somatosensory cortex connectivity and auditory and visual cortex connectivity. And these areas are shown in the plots. We next asked how similar are these effects of ketamine to the thalamic connectivity effects we see in schizophrenia and the clinical high-risk syndrome. And for this, we used resting state connectivity data from samples we had from chronic schizophrenia patients, early schizophrenia patients, and clinical high-risk patients. This slide just shows the areas that are showing greater connectivity in schizophrenia than healthy controls in red. The ketamine showing greater connectivity than placebo in dark blue. And then in purple, what you see is the conjunction. Conjunction means these are the areas that overlap between the two. That these are the areas that they have in common. So this is by way of just showing that areas that are implicated in hyperconnectivity with the thalamus and schizophrenia tend to overlap with the areas that are showing hyperconnectivity with ketamine. And to drive this point home even further, we did this analysis where we took the ketamine thalamic disconnectivity map. That means ketamine versus placebo. Where are the areas where ketamine differed from the placebo in thalamic connectivity? And it's you have values at every voxel in the brain for that. Then we also have single subject participant thalamic disconnectivity maps that are expressed as deviations from the healthy controls. So z-scores representing abnormalities or deviations in thalamic connectivity relative to healthy controls. And in the case of the ketamine map, deviations due to ketamine relative to the placebo. With that, we can turn these into vectors of numbers and then correlate them and get what we call a ketamine similarity coefficient for each individual. So this just represents the degree to which their thalamic disconnectivity map correlates with the template of the ketamine disconnectivity. And the first thing I'll show on the right is the comparison between healthy controls and patients with schizophrenia, where you can see there was a significant greater similarity to the ketamine effect in the schizophrenia patients shown in purple relative to the healthy controls. We also saw this for the early schizophrenia patients and the clinical high-risk patients who showed an intermediate value, but still significantly different from healthy controls. And finally, this is just a correlation showing the similarity, the greater the similarity to the ketamine effect, the more severe the SAPS hallucination score. So the more severe the positive hallucination severity. So just in terms of limitations of this study, and most of the studies I presented on ketamine only used one dose of ketamine. Ideally, that we'd be able to demonstrate dose-response relationships. We also used a whole thalamus seed rather than seeding different thalamic nuclei. This is consistent with prior literature, and it's also true that nuclei-based seed studies have tended to generate similar results. So I'm summarizing now. So ketamine produced similar effects to schizophrenia on auditory P300. Among the ERP biomarkers tested, P300 proved to be the most sensitive to ketamine, more than mismatch negativity, although most people in our field would say, well, mismatch negativity is a good biomarker for NMDA receptor function. If you're looking for sensitivity, P300 is more sensitive. Specificity may be a different matter. There was a weak MMN reduction with ketamine, and again, this may be dose dependent. We might have seen more with a higher dose. Reduction of MMN by ketamine is supported, though, by meta-analyses. There have been many studies that have challenged MMN with ketamine. Ketamine also induces thalamic hyperconnectivity with sensory motor regions, including somatosensory, visual, and auditory regions that resemble the pattern we see in schizophrenia. This effect was not reduced by lamotrigine. I didn't show you that slide, I apologize, but there was no effect of lamotrigine in blocking the ketamine effect, suggesting that it may not have been mediated by downstream increases in glutamate release. Alternatively, the lamotrigine may not have been strong enough to offset the increased glutamate release from the ketamine. We did not see ketamine-induced thalamic hypoconnectivity with prefrontal cortex and cerebellum, unlike the schizophrenia pattern. I believe there's another slide. Okay. So in conclusion, reduced amplitude of EEG-based ERP components, mismatch negativity in P300, and fMRI thalamic disconnectivity are predictive of clinical outcomes in the clinical high-risk syndrome. Ketamine challenge studies implicate NMDA receptor hypofunction as a possible mediator of these biomarker abnormalities. And these biomarkers may be useful in future clinical trials aiming to discover novel medications for the CHR syndrome. In how? By screening in those at greatest risk and screening out those most likely to remit, and by serving as measures of target engagement for drugs targeting NMDA receptor hypofunction, for example. And this is a very timely topic in light of the currently active in recruiting and about to advance to the next phase, Accelerating Medicine's Partnership for Schizophrenia. And this is where I end. This is very large-scale partnership between NIH and the Foundation for the NIH, which brings in industry partners who invest in this to try to accelerate the advancement of medicine development in this space. The first AMP that's been funded for a psychiatric disorder is schizophrenia, and it's focused on the clinical high-risk syndrome. And we are about to embark in the next 5 years on several clinical trials with novel drugs, aiming to try to break ground with alternative treatments in this space. So on that note, let me just acknowledge my collaborators, particularly my mentees who worked with me on many of these studies and projects. Thank you. Tom.
Dr. Mathalon,
Yeah.
can you repeat the question for the Zoom audience, please?
Yeah, so the first question was, are they mismatch negativity and P300 results the same people or different people? Are they independent or they're correlated? So they're not highly correlated. They are from, I mean, the results I showed are from the same sample. But this has been now replicated in multiple samples, but they tend not to be very highly correlated. Whether they can endure being side by side in a multiple regression analysis where both survive, that's a little bit of a different matter, but they come close. And then the second question was the new Karuna drug, this muscarinic agent. This is a breakthrough for the field in terms of having our very first FDA-approved drug for schizophrenia that's not a dopamine blocker. This is hopefully just the first of what will be many. The effect sizes don't look to be tremendously large. So I doubt that it's going to be a transformative drug, but it is something that provides us with our first alternative, particularly for those who don't tolerate the dopamine drugs very well or don't respond to them very well. And we don't know yet what drugs will be tested in the next phase of the AMP-SCIT study. The industry partners are still trying to decide that. But it is possible that this could be one of the drugs that we would test. And it's an example of what we're looking for, a drug that can address positive symptoms without producing the side effects that make it unwise to introduce antipsychotics at the clinical high-risk phase.
Hi, Dan. Oh.
Cortical glutamate release. Would you expect that to maybe have a better chance of having a long-term effect if given when symptomatic, like renormalizing thalamocortical glutamate release?
I don't know how to answer that. I think it's an interesting question. I think that there are going to be a lot of opportunities for new science with this the new drug to understand how it works differently from the dopamine drugs.
Hi, Dan. Thanks for the talk. My question is, how do you think about other comorbidities? So we have many CHR kiddos have depression and major depressive disorder, are diagnosed with anxiety disorders, and also arrive with trauma histories as well. How do you think about new drugs targeting these areas and then thinking about how they may work in conjunction with the other presentations that we see in the CHR group?
Yeah, so, certainly the field right now does recommend treating comorbid conditions, including with medications. And by and large, the medications we use to treat depression and anxiety are safer than the drugs that we use to treat psychosis. But one of the charges of this AMP-SCIT project, which I didn't mention, has 43 sites around the world, all harmonized in collecting exactly the same measures in exactly the same way. It took a long time to get this launched, you can imagine. So we're recruiting over 2,000 CHR individuals. And one of the goals is to try to identify subgroups, including subgroups based on clinical histories and profiles that may have different biomarker profiles and ultimately may respond differently to drugs. So I think that ultimately we are interested in trying to parse the clinical high-risk population into more homogeneous subgroups and try to tailor treatments that fit those subgroups best and help them the most. Thanks.